Today's forum, HealthMap 2016, is part of CMC's Our Healthy Communities series presented by OhioHealth, represented today by Karen Morrison and Shauna Davis, along with their associates. Please help us thank them for their series support. Today's forum is also sponsored by a number of other sponsors who we will recognize: the Ohio State University Wexner Medical Center, Jones Day, the National Church Residences, Mount Carmel Health System, PNC Bank, Steptoe & Johnson, and Cardinal Health. Won't you please help me thank these sponsors and then welcome Diane Radigan, Vice President of Community Relations with Cardinal Health, to introduce today's speakers. Diane?
Thank you, Mo. Thank you to everyone who's here. Jane, is this the largest audience? Here, yeah, 400 or so, some of us here, and we're really packed in this room, and it is a great, great venue. I think it says something about our speakers today and the interest in health and healthcare, which is what we're going to hear about today. So I have the privilege of introducing our speakers to you today, but their bios, all I'm going to do is read their names and their titles. Their bios are in the program. Please take a look at them because that will give you much more background. I want to thank CMC for continuing to host these important conversations in our community, and these on health and healthcare are especially poignant. So without further ado, we have David Blom, who is President and CEO of OhioHealth, Steve Allen, CEO of Nationwide Children's Hospital, Sean McKibben, President and CEO of Mount Carmel West, and Sheldon Retchin, who's Executive Vice President of Health Sciences at OSU and CEO of the OSU Wexner Medical Center. And our host is Mary Yost, who is the editor of CEO magazine and comes with her own bio in the area of healthcare as well. So we're in good hands. I will turn it over to Dr. Retchin, who's going to start us off with a brief overview of the HealthMap, and then Mary will lead the conversation. So please join me in welcoming our panel.
Thanks, Diane. Good afternoon. As Diane said, I heard this is a sellout. In fact, I was online last night, and there was even a little action on StubHub. This is very obviously a very popular event, and we're just delighted to be here. So on behalf of the Central Ohio Hospital Council, thank you for the invitation to speak at the Columbus Metropolitan Club. Before I get started, it's always a risk to recognize or acknowledge someone, but I'll acknowledge the CEO of the Central Ohio Hospital Council who's with us. Jeff Klingler, would you stand and be recognized? Now, I've been proud to call Columbus my home for just about a year now, enjoying the Central Ohio Hospital Council. And at the first meeting when I walked in, I think it's like one of those meetings where they need a volunteer to be chair and everybody stepped back. So as a rookie and being chair, this has been a great experience. And I've been pleasantly surprised overall for the entire community. This is a great community. I've fallen in love with it. The culture of collaboration that's here, as witnessed not only by the panel, but all of you here, is just remarkable. Very different from the community I came from, Richmond, Virginia, great place, but the culture here among civic leaders and employers and in so many endeavors really do make this city great. This spirit of collaboration exists within the healthcare community, as I alluded to, as well. And I must say, this is highly unusual, not unique, but very unusual for health systems in one city to collaborate on community health issues like we do in Columbus. Our hospitals collaborate regularly with a lot of partners: the city administration, the county administration, and state health departments, many nonprofit organizations, all to improve the health of our citizens. Clearly, we subscribe to the mantra that we're all better together. And not only do we say it, we live it right here. So let me just give you a little history and context for today's discussion. So the Central Ohio Hospital Council was formed in 2008 to bring the city's hospital systems and other stakeholders together to address community health issues. Really noble intent remember, this is a very active marketplace as it is everywhere. But over the years, we've worked together on issues familiar to you that we'll also address today: infant mortality rates, mental health and addiction, quality improvement, and also issues of procurement like supplier diversity. 2 years after the council was formed, the Affordable Care Act was enacted into law, and the ACA required hospitals to conduct needs assessments for their communities and address those needs every 3 years. That was a natural extension of the council's work, so that we could all join together and do this together, and allowed the 4 hospitals and health systems to take a more comprehensive look at the community's health care needs. The hospitals in Columbus mutually agreed that the best way to serve our community was through one broad assessment, coordinated with our local public health agencies and other key stakeholders. So the first Franklin County Healthcare or HealthMap was published in 2013. You may have reviewed it then. And we're here today to share the 2016 report with you. Now, you're all going to receive a copy as you leave today. There was sort of a vote and debate whether we give it to you before or we give it to you afterwards. And as a faculty member who teaches, I know you'd be thumbing through it like a syllabus. So we thought we'd make this a lot more conversational. First, we'd like to thank our partners who provided valuable input during this year-long assessment period. Representatives, obviously, of the 4 hospital systems, the Central Ohio Area Agency on Aging, the Central Ohio Trauma System, Primary One Health, Columbus Public Health, Franklin County Public Health, Healthcare for the Homeless, the Ohio Department of Aging, the Ohio Disability and Health Program of the Ohio Department of Health, and United Way of Central Ohio. And that is a lot of people joining together, arm in arm. How about giving a warm round of applause? We'd also like to thank our contract partners who helped us with the report, Brickers and Eckers Quality Management Consulting Group, the Ohio State University Center for Public Health Practice, and the research firm Illuminology. Now, through a facilitated process, the group of stakeholders identified 6 areas of health need in the 2016 Franklin County report. These won't be a surprise to you, I'm sure. But I think it's reaffirming that the areas of emphasis for our 4 health systems are areas of burden for our citizens, things that we need to focus our efforts on to improve the health, well-being, and welfare of our community. So those areas, and really in order of importance. Number 1, obesity. No surprise to you, our rates are above the national average, especially for children. Ohio, in general, ranks very high. Number 8 out of 50 states, and the obesity rate's approaching 33%. So both for adults and children, we feel like this is a number 1. It's a health epidemic that we need to focus our efforts on, not only as a nation, but clearly in Ohio and in the Franklin County area. Number 2, and maybe this is close to a tie, but it's infant mortality. Again, no surprise to you. I was shocked to look at the infant mortality rates in Franklin County and Central Ohio. It's a persistent problem in our city. Our rate is far above the national average, and it's not something that we should be proud of, and it's something that we're all putting great efforts in, and you can hear more about that. But just a couple of facts that you can get on Celebrate One, if you look at that website, and a shout out to the community and the city administration for embracing infant mortality as a major problem in Central Ohio. And some of those results you'll see on the website for Celebrate One, that there's been a great effort to enroll pregnant women in Medicaid, about a 40% increase, which is a step in the right direction because it provides access to great prenatal care and postnatal care. 3 families lose a baby every week in Franklin County. 3 families, 150 infants a year. And I don't have to tell you about the health disparities. African American babies are dying at twice the rate of white babies. So health disparities, the infant mortality rate in general, we feel is a very important health care need for our community. Number 3, access to care. Now, Medicaid expansion has done wonders, but my experience there is this takes time. But nonetheless, we exceed the state average for people who use hospital emergency departments for non-urgent reasons. And that takes a lot of time to change the culture and to get hooked up in primary care as well, but that's our number 3 priority. Number 4, mental health and addiction. Reported cases of domestic violence and child abuse have increased. I know you know that. You see it on the nightly news. But the the linkage between mental health disorders, addiction to opioids, and domestic violence is undeniable. This is something that affects our community every corner of it, and it's in national news. This is something we also feel is a high priority for our systems to be focusing on. And number 5, chronic health conditions. Mortality rates for heart disease and the top 5 cancers exceed national average, and it's an area that obviously is very natural for us. We not only focus on acute care, but also care in the outpatient setting and looking at chronic diseases. So that's our number 5 priority. And finally, number 6 is infectious diseases. And it's not just that dreaded mosquito, but sexually transmitted diseases are significantly more prevalent in Franklin County than in Ohio and the nation. The figures are staggering, and you can go online and look at those as well, and that's also a top priority for this. Now, the good news. We've seen improvements. Those improvements over the past 3 years in areas such as adolescent pregnancy, suicide rates, cancer, diabetes, high cholesterol and asthma. And there's a 2-year lag in these data, so maybe there's even more progress that's not reflected in the report that you'll see. Nevertheless, we still exceed state and national averages in these areas, and we think that we cannot rest on our laurels or just see an improvement. We've got a lot of work to do. Meanwhile, infant mortality persists, and new health challenges continue to arise. Assaults and accidents are on the rise, and fewer people are getting important and vital cancer screenings. These issues must be addressed to ensure the healthiest community for our families and for all our citizens. Now, over the next several months, each of our hospitals and health systems will review and examine this report in detail and develop strategies to address its findings. We'll present those strategies to our governing boards for review and for approval. We're already collaborating in a bunch of areas. I can tell you at our meetings, we are very lively conversations about what we can do, what we should do, and focus our efforts, such as in infant mortality and mental health. I can tell you, I look forward to these meetings every month, working with my colleagues here to attack these problems in the community. And I'm sure that we'll see other collaborations as well through the Central Ohio Hospital Council with Jeff as a leader and with many of you as community partners. So that's a Cliff Note review of the Franklin County HealthMap 2016. I encourage you to read it and read it thoroughly after today's meeting. And I really appreciate your attention and your role as partners as well in helping to make Columbus a great city in which to live and work. Now I believe our moderator, Mary, is going to come up here and have some questions about our findings, and we thank you for being here today. Thank you.
Thank you. This is a great privilege to be up here, and I hope that you all appreciate, too, what a privilege it is in our community that these people and their systems work well together. I know that Dr. Retchin mentioned the collaboration is rare, and Sean, I know you came to Columbus from Cleveland. Can you imagine this kind of an event, this kind of collaboration occurring in Cleveland?
Well, Mary, the simple answer is no. It's a wonderful healthcare community with a lot of great health systems up in the Cleveland market, but not the level of collaboration that we've seen in Columbus. I've been here 5 years, and it's been a fantastic opportunity to learn how to collaborate for the betterment of the community. Trinity Health, our parent organization, has regional ministries in 21 states across the country. And while Columbus is probably one of our most competitive markets, it's also our most collaborative market. And I think a lot goes to the Central Ohio Hospital Council and the formal structure that we have.
Thank you. And Dr. Allen, I know the children's hospitals even have found ways to collaborate with the adult hospitals.
I think one of the things that characterizes Central Ohio is that all of the health systems are very mission-driven about not denying a patient because they can't pay for it. So that mission tends to override some of the other things that might get in the way of us trying to make sure that we provide the best possible care. So there's, as Dr. Retchin had pointed out, there's just any number of initiatives that that demonstrate how well we try to work to see about utilizing your community resources toward the betterment of the health of this community.
The health map that everybody is going to receive at the end of the luncheon today has some data in it that's a little bit dated. I think it's from like 2012, 2013, but you have other indicators to give you some clues that the things that you're working on together are on the right track. Where else do you draw from to know that you're tackling the right health issues in the community? And Dr. Retchin, I won't ask you to address that because you're still new to the community, but is it things that you hear from other business leaders? Is it things you hear from health payers? What are some of the other sources of information?
I'll jump in here. So, it's pretty evident when you go into our institutions what's needed, because they show up in the emergency room every day. And I'd say one of the biggest problems we're trying to attack now is mental health. I can't tell you the number of patients that have been in our beds at any of our institutions for 24, 36, 48 hours, 60 hours. And that's no place for them to be. But there's no place else for them to go, because that is defined in this market by their ability to pay. We have a system for those who can't pay through the Adam H funds, and there's also defined where they go by whether they're Medicaid or not, or with commercial insurance. So you got three different buckets of patients, and their disposition as to where they go is governed by their payer. With Medicaid expansion, while that's great for most things, it put more people on the Medicaid rolls, and that is the most difficult group to place because there aren't enough beds for Medicaid patients because they can't go to the system that takes the self-pay. You with me? So we're, the four of us collectively, as well as our government relations people and our associations, are working diligently to have a federal law changed so that we can send Medicaid patients to the for-profit sector. There are 228, Jeff, is that right? 228 beds? Got it right. Being built in this community right now that are for-profit psychiatric beds. Right now they can't take Medicaid. So we're working collaboratively to try to free that up so that can actually happen. Those kind of efforts would not occur were it not for our meeting, and that's a standing item on our agenda to help deal with it. There's a lot of other things we're doing with bed boards and collaborative planning and a whole variety of things, but it's the Medicaid issue that has creeped up, and we will not have capacity, and it's up to us to leverage that.
If I could jump in on two items that Dave just mentioned. So to give you an example, Jeff Klingler loves to give this example. Last July 27th in our community, we had 94 patients in our hospital's emergency departments. We had 7 beds available to place these patients amongst the hospitals. Of those patients, 60% were Medicaid patients. So you can imagine if you're a community member, you have a loved one sitting in our ED, and we literally had no access points to place over 50 patients. So that's why it's so important that we come together and collaborate from a payer standpoint. I think the other answer to your question as well, Mary, related to the emergency departments, we also have tremendous outreach in the community. Everyone has access to our community benefit reports, and we spend a fair amount of money with outreach initiatives. One of the initiatives that we're embarking on as well is a Project Dawn initiative, which focuses on reversing some of the effects of the opiate addiction that we have in the community. 33% of the overdoses in the city of Columbus right now come to the Mount Carmel West Emergency Department. So we're partnering with our mobile outreach right now to ensure that we are involved in the Project Dawn. We have our government relations leaders working with all the hospitals to provide education and the Narcan kits. So there's a lot of things that come into the emergency department, but there's also a lot of things that we do from an outreach perspective to make sure that we have the temperature of the community and what the challenges we face.
Great. And I think most of us would agree it's not just the job of hospitals to improve community health status. Have you seen in recent years broader ownership in the community from whether it's corporate leaders, nonprofit leaders, others who are coming to the table to try to help take ownership for improving community health status? And if it's not happening, how can we get it to happen?
Oh, I think that we, at least from our vantage point, we see a great deal of community benefit. We have a neighborhood revitalization effort going on in the 3 zip codes that include the Nationwide Children's main campus and just to the south of us. And when we went and said we wanted to try to make this a better place for the people who live there now to stay there, we've had any number of groups come forward to help out. I think it just speaks really well to the spirit of collaboration. I think the expectation that the community has for people who run their civic organizations to participate.
Great. Is there an area where it's not happening, where we need to light a fire under some people?
You know, and again, I come from a relatively narrow scope compared to my colleagues up here. You know, generally say we think this is a good thing for children. People tend to rise up and try to be creative about how we can try to address some of those issues.
Great.
I think there is a place to light a fire, and that's us as being consumers. Increasingly, I think we, all of us, have to take a greater responsibility for our own health. Employers are understanding that, and the employee benefit plans are being changed to be more consumer-centric, to put more of the decisions on lifestyle and how folks buy their health care services in their hands. And that is an issue that's evolutionary, and I think we're in the early stages of all that. I think we're seeing the employers realizing they're having a difficult time managing their health care costs, and they can fuss with plan design every year and try to make it a little better. But the thing that has worked the most for them at this point has been shifting the risk to the employees or the consumers. And that has had an initial impact on their health spend. I think most sophisticated employers are understanding that that first bubble only lasts for so long, and that an investment in the employees at work, whether it's on-site wellness or managing chronic disease, is something that will help them manage their own health spend. So I guess my opinion is the fire is us.
I think I'll focus on another area, the population, getting back to. I think one thing we really need in the city and the region is continued focus on vulnerable populations. University Hospital East, where we held and hold health fairs with surveillance for colorectal cancer. Those are things that even though, and let's celebrate the expansion of Medicaid, one size doesn't fit all. So these are underserved, often undercovered people who, if we're going to close the health disparity gap, and that gap is huge, we're going to require all hands on deck. It's not just the acute care facilities and executives, but it's also the provider community and businesses working together.
Great. Now we're going to be moving to questions from the audience in a few minutes. So if you want to get your questions ready, you'll have that opportunity shortly. But before we go there, where we find ourselves as a society right now is that there's a big election coming up later on this year, and there has been some talk about what the future of healthcare reform will be, whether it will be full steam ahead or undoing of some of the or all of the Affordable Care Act. What are your thoughts or concerns about how the elections may impact any momentum that's in place?
If
ready for this one?
I think if the Democratic Party wins, it'll be tweaking it, and if the Republican Party wins, and depending on the House and the Senate, it will be repeal and come up with something new.
I'll jump on that. So I think the tweak will go this way. I think if the D's get in and control, well, actually, if the D gets in the White House, then I don't think anything's going to happen because I think it'll be a standoff. So if they and clearly, I think you can be pretty confident that both houses, the Senate and the House, aren't going to go. But if the R's get in, what I think will take place is really probably something that Paul Ryan's been pushing, which is block grants. So Medicaid will be reconfigured, allowing states to not only experiment, but to have a lot more flexibility in terms of benefits. I'm ecumenical, so that, but there clearly those, I don't really see Medicaid expansion and those kinds of, and the exchanges being totally reversed. I think instead it'll be more deliberative with states.
And Steve, did you want to add something?
Yeah, I think that as much attention as the Affordable Health Care Act has gotten, and deservedly so, that the overarching trends that were impacting American healthcare predated the passage of the ACA. Regardless of what happens with tweaking of it, it'll continue to be the challenges that we just have a healthcare system that continues to still be too expensive for us to long-term sustain, I think will cause at some point Congress to look at the entitlement programs and make a decision. But one of the perspectives that I have about the ACA, to go back to that, is that when Medicare and Medicaid were passed in 64 and 65, there has yet to be a congressional session in which one or both of those weren't tweaked in the intervening 50 years. It's unlikely that ACA won't have some tweaks to it over time. But again, the things that are occurring with how each of us looks at employee-sponsored health insurance, those are occurring independent of what happens to ACA and probably will continue to create challenges. And I think part of the fun of getting to do what we get to do for a living.
Great. Okay, we're almost ready for the questions from the audience, but one more. So every industry is facing disruption of some sort these days, and maybe the Affordable Care Act has already disrupted health care. Is there any consensus about what some of the next disruption will be to impact how you deliver health care, or what kinds of health care people are seeking?
I think one of the big disruptors that we're facing is consumerism. When you look at, the statistics, 165,000 healthcare apps exist out there. 75% of internet users say that they seek healthcare information on the internet. We have 4 different generations that we're taking care of right now. So consumerism is here, transparency is here, and I think that's one of the things that we're truly going to have to address is healthcare delivery systems, is how do we compete? How many of you right now have a primary care physician that offers Saturday hours, that offers evening hours? We need to do a better job as a healthcare delivery system of addressing those consumer needs. And some of the reasons why we have overutilization of emergency departments in the state of Ohio is we haven't necessarily addressed the foundation to make sure that we're keeping up with the times. Telemedicine, I think, is going to be a big disruptor. I think the way people get their health care. So there's a lot that we have to do related to consumerism.
I'm just going to really quickly add.
Real quick.
Yeah, I think the real disruptor out there in the next 5 to 10 years is applied genomics. hold on to your seat, because that's the applying genomics, particularly in cancer, but other conditions as well, are going to be able to get targeted, not only diagnostics, but therapeutics, and will revolutionize medicine.
Great. Okay, it is CMC's tradition to take audience questions. And as you move toward the microphone, I can't imagine a room this full does not have a lot of people who want to ask questions. Please state your name, ask your question, and we will thank you in advance for not making long editorial comments. And I think, Andy, are you going to give us our first question?
Sure, happy to ask one to start off. Andy Campbell, thank you all for being here today. You mentioned briefly the telemedicine, and I know access to healthcare is one of the really big issues. Can you talk about how you can maybe outreach to some of the communities and make medicine available, especially for those chronic diseases, diabetes, heart disease, those sorts of things, and for an aging population, how that might impact what it looks like to be a hospital?
In terms of the effects of telehealth?
Yes, sir.
Yeah, I'm sure my colleagues have had the same experience, but we use telehealth particularly for the management of stroke in rural areas where the academic health center can see a patient distant in terms of the stroke event itself and get thrombolytics to the patient very, very quickly. But also in other populations that can't really, when the visual identification of the patient is of help. I think that'll continue to grow, but also maybe even a little more on the micro level, so individual physicians with patients at home.
And it is proving to be a help on the mental health problem that I was talking about. Telepsychiatry has turned out to be a very effective tool in helping take care of patients where there's not that professional there with that patient, and has been quite effective in dealing with that ER problem that we were talking about.
Great. Yes.
Hi, Debbie Goff, infectious diseases pharmacist at Ohio State. I was happy to see that infectious diseases ranked as one of the 6. So my question is, with the global spread of antibiotic-resistant superbugs, globally and within our own community, President Obama and the Joint Commission has recommended mandating antibiotic stewardship programs to oversee the antibiotic use in all hospitals, but knowing that antibiotic-resistant infections cost twice as much to manage and have poor patient outcomes, do you view these programs as cost-saving programs for hospitals or more quality improvement, patient safety initiatives? I'd like your opinion on that.
Thanks for the question. I think it's an important component because what an antibiotic stewardship program, which is really, just for those in the audience, this basically allows a central group in a hospital or health system to kind of monitor and not overuse antibiotics where it would generate a resistant bug. And there you have the kind of trade-off of individual health or over-treating a particular individual versus the public health for a population. So it's a fine tension, but I think the antibiotic stewardship program that we have at OSU and other places is of absolute paramount importance for health systems to focus on the overall population, where we collaborate on something like that, even though for the individual it's a more difficult decision.
Any other thoughts on that? I know you've done a lot of work collaboratively on reducing infectious diseases, period, in your hospitals. All right, next question.
Hello, I'm Jim Bruner with the Past Innovation Lab, and my question comes from a student. She was doing research on how patients interact with hospitals. As hospitals and caregivers increasingly go more and more digital, she uncovered what she sees as an emerging health crisis in vulnerable and low access, low economic variable people without access to high-speed internet or email and being able to schedule appointments and getting access to their medical records and understanding what their medical records are saying. Do you see this as an issue, or am I and she alone in that opinion?
Doubtful, but...
Yeah, I'd say that we're surprised with how, and we run low-income clinics throughout Central Ohio. Almost everybody has a smartphone these days. If we have a challenge, is that the number changes. And so we need to come up with, and particularly because we want to interact with a parent, but we also want to be able to directly interact with the child. So we have some privacy issues we got to figure out how to do with that. But we're very encouraged that people can usually get access to that to a phone, and trying to figure out a better way to educate them about how to better manage their disease or their child's disease. I think for all of us, we think this is clearly the direction we need to go in, but it's still something that's in development, because the things that seem to have face validity don't always work out. So we just got to continue to figure out what people are going to respond to, interact to, and gets the kind of behavior we're looking for, but gets them the understanding that we think that they need.
And on the connectivity issue, one of the things that we've done at Mount Carmel is we have a Healthy Living Center stationed on the Mount Carmel West campus, where we actually have educational opportunities. We have computers set up for the public where they can come in and actually use the access points free of charge. So it's been a great endeavor. We've had over 17,000 visitors to the Healthy Living Center. So we're also offering some opportunities for people to become more connected.
All right, thanks.
Hi, thanks for being here. Warren Fishman. At the beginning of the forum, it disturbed me. I knew about the high obesity rate in Franklin County because we have no mountains, no ocean, and we're great spectators as far as sports. But the infant mortality rate, there seems to me, as I've traveled the United States, there's a lot of poorer cities and larger cities than Franklin County, and I wonder why we have a high infant mortality rate. Higher than other cities.
Yeah, so it's multifactorial. If it was a single factor that was contributing to the numbers, it had been fixed by now, as has been for a number of other public health challenges. I'm very proud of the fact that all four health systems work together with Teresa Long of Public Health, as well as our mayor, to walk through a months-long process to understand what the various factors are that contribute to the unacceptably high infant mortality rate, and to come up with a plan. And now it's a program called Celebrate One, which is co-chaired by Donna James and Michael Fiorelli, and has the support throughout the community to go in and target what we think are interventions that have been proven in other communities to get the rate down. So I think it's something that the community needs to hold all of your institutions accountable for, because our children deserve better. But thank you for asking that question. It continues to be something of importance to all of us.
It's not just, it's a socioeconomic problem rather than just a clinical problem. It's not a matter of just having enough resources. It's dealing with communities, women and babies where they are, not necessarily within the institution.
All right, and I think it's one of the great things that you've done is there's been a lot of community education in terms of how infants should sleep, and just some basic education. So hopefully we'll start to see some turnaround on those numbers. Next question.
Bill Wayhoff, Steptoe and Johnson, PLLC. I was wondering if your collaboration has included discussing solutions to security issues for your institutions. Thank you.
We've not collaborated on the security on the front end. We have collaborated a lot on the back end. What happens if you don't have it? How do you deal with disasters? How do you deal with those kind of things? On the front end, we have not. Other than a number of years ago, we all agreed we were going to put the things you walk through, go in the ER, those. And that's something that we all agreed that we would do up on the front end.
Any other security thoughts? All right. We have another question from the audience.
Great. Hi there. I'm Jennifer Sisto. Grew up in Columbus, Ohio, but actually just studied public health at UC Berkeley. And one of the things in Silicon Valley you find is that price transparency tools are actually failing quite greatly. If you notice the stock price of Castlight or other ways where consumers are trying to shop, I actually interned at OhioHealth many years ago, so I was excited to come back and discuss this with you. And I wanted to just focus in on the ability for health systems to think of ways to make hospital bills and charges more transparent, so even on the back end, consumers can understand really what they're purchasing. So that's my first question, is just around how health systems can work in this new era of price transparency, and are there ways you can impact that? And the second was, we spoke a lot about the ACA, but there's also Medicare's shift towards value-based purchasing, so 90% by 2018. And I'd love to hear how that your health systems are working collaboratively or with payers, or how you're going to approach those new things like bundled payments and for oncology and joint replacement and things like that.
That was
We're going to need another 10 minutes.
That was a big question. So I'll start with price. It's hard because we got different prices with every single payer. And then even with different payers, we have different prices on different plans within that payer. And the software doesn't exist today to make that very easily done. I think you will see it sooner rather than later on outpatient prices, where there's more consumer-centric behavior driving those choices. But it is something I think that you will see within the next 3 or 4 years. In fact, the state of Ohio is trying to mandate it. Well, they can mandate it all they want right now, but we can't do it. But I do think that will happen more in the future. I'll let someone else deal with the value.
And on the value equation, and just for all of you in the audience, it's basically we get paid for how much care we deliver right now. In the future, we're going to get paid for how well we deliver that care. So we're very, very focused. We know the pendulum is going to swing. Right now, we have 12 innovative products right now from accountable care organizations. We've got our Medigold products. So we're really challenging our physicians. We're working with the payer community. We've gotten great feedback from the payer community right now, but it is tough. Medicare is swinging the pendulum on value. We live in a fee-for-service world right now, so it's not going to be an easy 2.5 years. We're doing a lot of things right now. We have 200,000 lives at Mount Carmel under risk arrangements, if you will, but there's going to be a lot of work to be done. And back to Dave's point about the compliance. That's another big challenge and opportunity that we have, because in a value-based system, we just talked about chronic conditions and the amount of money that's costing us. We just talked about obesity. We just talked about access to care. So we've got a lot of work cut out over the next 2.5 years, but I know everyone's very focused on changing the delivery system.
So I just was going to add in, just to pile on with Sean's comment, at Nationwide Children's Hospital, my CFO, who's back there, Tim Robinson, about 20 years ago set up a complete at-risk plan, what's called Partners for Kids, where we now go at complete risk for 330,000 children in central and southeast Ohio. We've been able to show that by getting first dollar access to these kids, we not only can bend the cost curve, but we can sustain or improve the quality of their health care. And I couldn't agree more. I know my colleagues and I have talked about it. That is the way that American healthcare is going to have to go. Thank you for your question.
I think we need to be less concerned in the future just taking care of the sick and injured, but the health and well-being of those that we serve.
Thank you.
Hello, Daryl Gray, Ohio State Wexner Medical Center in the James. All of the outcomes that were mentioned that Ohio is performing poorly in are directly linked, the 6 that were mentioned, directly linked to social determinants of health: education, income, employment, housing. How can the medical centers work together to address those social determinants? For example, I know that Ohio State, particularly on the Near East Side, is working with PACT, or have formed PACT, in which they're influencing Columbus City schools, health through health science academies, impacting housing. But how can we spread this beyond the Near East Side to address all of Ohio?
Well, I think each of us have taken on a community. I know that Mount Carmel has put a lot of effort, initiatives into Franklinton. In ours, in the 3 zip codes surrounding us and going south, we've had a 5-pronged program over the last 8 years now that has substantially had an impact on that. I think I think neighborhood revitalization programs are important. It's one of the key aspects of Celebrate One's success. So it's important to have an anchor institution, but what we have learned over this time is that we have to go and find resources within the community to help lead and collaborate those. It's not just, it's great for us with our resources to go in and try to tell people what we think their problem is and how it's going to fix it, but that doesn't work as well as if we can develop and cultivate the relationships with the people who actually live there and help and have them educate us about how it is that we can make things a little bit better. Great question.
I'll just add, and you spoke about PACT, and I think that's a great example of a public-public and public-private partnership. And I said earlier it's going to take all hands on deck, but it's going to require the business community as well to revitalize neighborhoods because, as you're pointing out, I think accurately, this isn't just a health problem. This is really socioeconomic. And as Columbus, the climate and environment for business and jobs improves, I predict that the scourge of poverty will improve as well. So it's a good question.
Good afternoon. My name is Doylene Williams, and I work for Lardon and Associates. The question that I have pertains to concierge healthcare. Do you all envision that particular model will become a significant disruptor to the healthcare system?
I'll try that one on.
All right.
In fact, you said concierge? Yeah. So concierge healthcare comes in lots of different models, but one of them, I guess the most common one is in primary care, where someone pays basically a retainer fee. Could be $2,500, $5,000, $10,000. In New York, it may go $20,000 a year to have somebody on call for you 24/7. That's the model you're talking about? Did I miss it?
That's the model, but here in Columbus, it's starting around $1,000 to $1,500.
Yeah, it's probably an opening discount, and operators are standing by. So, you know, I've been...
Excuse me, and I'm going to be a little bit forward. That's not true because I do have concierge.
No, I'm sure. That's all right. I'm sure it's been great. You know, concierge healthcare really is amazing to me. That so there you have primary care that back in the 90s was rejected by consumers in large part, and that people want choice on just routine health care. So primary care kind of lost out early on, and then Americans turn around and want to pay extra for it. So I can't really, I think it's going to find its way in terms of a certain market, and I think that's possible. Do I see it growing? I actually don't think it's going to grow in large part. Some of the companies that have tried this, like where I came from, have struggled. I think primary care will, the change in this won't be the concierge, it'll be the growth of primary care and the recognition of its value for everyone, not just those that are going to pay extra for it.
And my only comment would be, I think that just creates a further divide of everything that we just talked about here today. We're talking about, you know, social disparities, et cetera. It's great for those people that can afford it, but I think that's, you know, if we're going to focus on that as a healthcare delivery system, it's just going to drive that further divide related to some of the social determinants of healthcare.
All right, I think we have one more minute for a last question.
William Martin from the OSU College of Public Health. First, I'd like to thank the panelists. This has been a wonderful presentation. In the context that you're representing four large, complex healthcare systems, you're also representing a good share of the business community in Mid-Ohio. And when we're trying to address issues like infant mortality, it's really just the tip of the iceberg for public health. And take any of the CDC priorities for public health. Unfortunately, in Ohio, we come out somewhere between 35th and 50th. So with that challenge ahead and the success to Celebrate One as a model, how can the health systems, together with the broader business community, improve life, and particularly for those vulnerable populations in Mid-Ohio, to make Mid-Ohio a safer, better educated, and healthier community. Because the health outcomes we think of, 80% of those are outside your control, and yet impact your emergency rooms, impact the cost of doing business. So is there something in Celebrate One that is scalable to address more broadly the public health problems in Ohio? And in doing so, work with conventional partners like Ohio Department of Health, Columbus Public Health, Franklin Department of Health, but also bring in non-traditional partners. And I would argue the public school education system, it correlates with public health nationally. And business leaders, I would think, would want a well-educated population besides a healthy population. And the same is true about transportation. The same is true for housing. How do you bring it all together in some system approach? So we're not back at the table in 3 years talking about another public health metric, but we're working together as a broad community to solve this problem.
You know, if I could, and I know we're running short on time, but I think one of the ways that we're doing that right now is regarding mental health. We have the Psychiatric Crisis Emergency Services Task Force, which all of the hospitals are represented. We have over 20 other community organizations that are represented there. We're funded by the Columbus Foundation, funded by Adam H. Board, and we put forth a set of recommendations back in February that talked about access, which talked about crisis intervention, which talked about the partnerships that we just talked about with payers. We actually had payers at our meeting yesterday. We had Dr. Long there as well. So I think from a microcosm standpoint, that's something we're doing with behavioral health. And when you talk about how significant behavioral health is, when you read the HealthMap report, 1 in 4 patients in this community suffer from some form of behavioral health disorder. 10% of the community 12 years old and over have sought care for alcohol or drug addiction. So when you think about how that plays out from an employer's perspective related to absentee, productivity, et cetera, it's a huge challenge right now in Central Ohio, and that's something we've taken head on. We're not there yet. We've got a lot of task force that are working now on some of the overarching solutions, but everyone is at the table working on the mental health challenge right now. So that's one example. I'm sure there's others as well.
I think it's a great question, Bill. And one thing I'll bet is that as you see one of the things that we haven't done really well is inventory what we're doing now that really fit your framework. And take those examples. You've named Celebrate One, but things that we're doing with the health system in these public-private and public-public partnerships where we're reaching out into the community, as I mentioned, at University Hospital East for surveillance efforts, things that we don't have to do, but we're doing exactly in the framework you're talking about that we could do better if we had those kinds of partnerships. So I think it's a great point.
Well, we're going to have to cut it there. We certainly could engage in this all day. Thank you so much for being here. Let's thank our sponsors for today, OhioHealth, Cardinal Health, OSU Wexner Medical Center, Jones Day, Mount Carmel Health System, National Church Residences, PNC Bank, and Steptoe & Johnson. And then again to our speakers, David Blom, Steve Allen, Sean McKibben, Sheldon Retchin, and our host, Mary Yost, for a great job. We're going to invite you to stick around for coffee and cookies to continue to discuss. Know that you can watch all of our forums through a number of outlets, including the CMC website and through Columbus Television locally. We look forward to seeing you again at next week's forum. Great job. Yeah, a little long today, that's right.